Yeah.
That's kind of how I felt like with nursing, like how we train, like try to educate new nurses when you're coming in. We call it like batching your work. So like when you're going in, we want you to be able to, you're going to get an IV, you're going to get blood work, you need to put them on the monitor, you need to do XYZ, whatever. And just kind of have all your stuff with you when you go in and actually start to get it done. Mm-hmm. So that way you're not coming in and out of the room multiple times, which then cuts down on your workflow too. So you want to make it as efficient, make sure the patient's getting seen and taken care of, and that everything's getting done quickly, because we're like, if you go in and the doc put in the lab orders, but you went in, put them on the monitor, but then CT came and took them, and then they're not back yet, and you're like, I still haven't got the orders, but you're in another room now, and it's like now you're slowing down the provider because you didn't get your basic stuff at the beginning because you were kind of piecemealing it together when you went in to do your actual tasking stuff. So we do kind of try to teach that to new grads as they're coming through. It's like, okay, we're going to batch everything together. We're going to go in at one time, get it done, move forward. And then we also try to teach them to think forward. Like, you have somebody who is coming in with chest pain. Well, what are you going to need? They don't look at them like, is one IV enough, or do you need two IVs? Do you need an AC, or can you deal with a hand IV? Do you think their doc's going to ask for a CTA or not? Do you think they're going to need XYZ, but also you try to get them to plan ahead too. It's like, okay, this is what I would do, plan ahead if things get worse, or if I don't need to do anything because I think this patient's going to go home too, along with the provider. Yeah. And then kind of like touching bases with them. It's like, what are you thinking? Like, okay, now that I know what train of thought you're on, kind of helps me with my train of thought too. So just asking those type of questions that kind of help with the efficiency of moving people through and keeping everybody's flow consistent. Because if one person falls off, I think it affects the whole chain of things.
Mm-hmm. And once you've seen enough patients, I think whether you're a nurse or whatever, you can anticipate what's going to have to happen for this type of complaint. And if you can anticipate things and they're done before they're asked for, it makes things move a lot faster. Yeah. That's what good EMTs do too. I think for paramedics is you anticipate, okay, we're running a chest pain call. I know I'm going to have to get a 12 lead on this patient. You can start doing that before the paramedic asks for it and stuff.
Yeah, absolutely. And it's what good paramedics do for their patients, right? Like efficiency is the name of the game, in a pre-hospital setting, because you have fewer resources, but you also have limited time. So even have fewer options to gum up the works and make you get confused about things. You also have like, well, I've got 10, 15 minutes and that's it. And so I have to have all this stuff planned out, but you also have to be anticipating. Now, what happens if the patient, suddenly starts to deteriorate? What do I do in that case? And not be suddenly scrambling for like all the stuff that you need while your patient is, crumping in front of you.
Right.
So yeah, it's a very efficiency based, even if we don't always use that terminology. It's all about like, the what's going to kill them first. How do you solve the problems? One of my favorite lines from the movie The Martian, it was not in the book. That's okay. It's a good movie. Is the idea of you solve the first problem that's the most dangerous, then you solve the next problem after that, and the next problem, until eventually, in the movie, it's you get to go home from Mars, and EMS, medicine, it's your patient hopefully has a positive outcome. But,
I think you see that a lot too. Like, I work night shift, and so like at our facility, it's the doc after 1, and sometimes you have like really busy nights where people are just still flowing in after the mid-level leaves, and to help the provider out, you kind of have to think forward. It's like, okay, is this patient that bad or are they not? Let me help them out by like, we already have like set standing orders that we can do, but for you to realize like, okay, this is an upper abdominal pain, they're going to want these orders, they may want this, or you'll see other things you could help the doc kind of see what they need to do, but kind of help them along, so that way they're not getting bogged down by like some of the mundane things, so that way they can keep the department moving too, like if they're in there with a critical patient, and you had 5 people check in, or kind of prep the patient for, you're like, hey, doc's just waiting for our results to come back, we're going to get you going, let me get your last set of vitals, let me get your IV out, blah blah blah, we're just waiting for your paperwork. So
I would also encourage providers to become comfortable with 2 naturally uncomfortable things, and that is saying no and saying I don't know. So we in medicine think that we have to do everything for everyone, and we think that we have to have an answer for everything, and we all know that that is very, very unrealistic, and there is no place in the house of medicine where it's more unrealistic than in the emergency room. So for example, saying no, talk about efficiency. You've got a young, healthy person, vital signs are perfect. They have cough, congestion, runny nose, sore throat. They've got a classic common cold. They are asking for a chest x-ray. If they would have never asked for it, would you have done the chest x-ray? Probably not. But just because they want this test doesn't mean they need it. And you're not being mean. You're not being wrong by saying, I'm not going to order that test. It's really not indicated. This is not consistent with pneumonia. This is consistent with the virus. And say it politely and hold your ground on that. Then the other aspect is saying, I don't know. Chest pain is a perfect example. Yeah. How often do we see chest pain? There's no shift that goes by that I don't evaluate at least 1 or 2 patients with chest pain. There's a positive test that explains their symptoms maybe 10% of the time. So we're talking 9 out of 10 times negative workups. Then there's a common question, well, what is causing it? Now, if it's classic musculoskeletal pain, you can say that. If it's classic anxiety, go ahead and say that. But most of the time, it's not. Most of the time, the story of the person who comes in with a heart attack is very similar to the story of the person who has no tests positive whatsoever. They're low to moderate risk. You're going to send them home. Well, what's causing it? Just be comfortable saying, I'm not sure what's causing it, but your tests are reassuring. I don't think there's a heart attack, a blood clot, a collapsed lung, this, that, everything else. So be comfortable saying, I don't know, and be comfortable in how you tell the patient that. And don't get caught in the trap of like, well, maybe I should add this. Yeah. Maybe I should add this. Maybe I should add this. It's kind of like Occam's razor. The first thought is usually the correct one. Not always, but usually.
I feel like our society in general is just overemphasizing like a specific diagnosis for every little thing. I don't know if the world just gets more that way, but I feel like everyone like wants to know exactly why they have this or that symptom. They want like a specific diagnosis that they can hold their hat on the rest of their life. I don't know. I feel like I just see that a lot in society, and it's probably not a healthy thing to always want to label everything.
No, it's not at all. Not only is it not good, it's genuinely bad if you take on the personality as a doctor or a PA or an NP to be the one who always has an answer, because you are trying to be something that is not realistic. And then you tell patients something that's just medically inaccurate, and then they go and run with it, and then it affects not just that visit, but every single time they experience that symptom for the rest of their life. We've all seen it, like, well, they have this headache. Well, my friend had this and this, and it doesn't mean that every single person who has a headache has that condition. So I would highly encourage people to be very comfortable saying, I don't know. And if you learn how to approach it, a lot of patients really accept that quite well.
Yeah, some of them don't, but most of them I find usually do if you can tactfully explain that to them.
And if they don't let that make you second guess yourself. Just understand that there are patients who are going to nearly demand an answer.
Yeah.
That shouldn't change how you feel or what you do.
Yeah. Ben, you see and train most of our EMTs and paramedics in this town. What kind of things do you see from them that we could kind of help them from the hospital side? Like, what struggles do you see with new medics or EMTs and their interactions with the hospitals and stuff that maybe we could do from our side of things that could be helpful to them?
Boy, well, I'll start by saying that, like, overwhelmingly, all the experiences, the majority of the experiences that all of our students have is very positive.
Oh, good.
They're very, very happy with going into the emergency departments and also riding along with our community partners on the ambulance and seeing all that stuff in action. I think the biggest theme I would say is that, once again, paramedic being sort of a new, and new is in heavy scare quotes here, but sort of a new discipline, people still don't have a very good idea of what paramedic is and what they can do. And because it is so variable from system to system, and it's so dependent upon the decisions of the medical director or the medical direction team, somebody who worked in Minnesota might have a very different idea of what to expect from paramedics bringing a patient into the emergency department, or the training for a paramedic student versus where we live or in California or whatever it is. And so a lot of the time, one of the things we hear as feedback from our students most often after their first couple shifts, especially for paramedic or advanced EMT, is they will say, here's the skills that I've been trained to do up to this point in our clinicals, in our labs, etc. So I can help with any of that. And they'll hear some variation of, I didn't know you could do that. Or, you know, you're not doing that out in the field though, right? And so there's sort of a bit of education about just like what does a paramedic do. So that I would say that's the biggest thing, honestly. Other than that, really there's a very little amount that can be controlled, right? I mean, the whole point of an emergency department is that like you can't control emergencies, otherwise they wouldn't be emergencies. It's a bunch of uncontrolled variables flitting about. And so giving them that experience really is the big thing. I think the other thing might be contextualizing it, especially for our newer students who are like EMTs or AEMTs with very little experience as an EMT. You can train, you know, a very smart primate, you know, like that you go break into a zoo and, you know, pick up a very smart primate. You can teach one of them to intubate. You know,
I would like to see that.
I mean, that'll be the day before I retire. That's but
like, not only do I want to see you train a primate, I want to see you break into the zoo to find the smart primate.
It's a multi-step plan. So I've got to start now, get that efficiency going. But, you know, a lot of the skills without context and without the understanding are just skills. They're just repetition. And that's, you know, it's fine for somebody who is just a bog standard technician who doesn't need to think about things. But as soon as you get to like provider, even like a lower level care provider, like we see pre-hospital, they have to have that context and they have to understand why not. There's so much received wisdom is a big problem in EMS education about things that are like not only not evidence-based, like not science-based, but not even evidence-based, right? That are just, oh yeah, I've been working with this medic who's been around since, you know, the sun was brighter in the sky and the moon was closer and the earth's crust was still cooling. And he says that if you do this, you know, it works every time. Like, here's how you really give Narcan. This is, I don't know how true this is in like medical school or nursing education, but it is a constant sort of revenant that keeps rising from its grave again in EMS education of these well-meaning lab assistants saying things like, well, there's the book way and then there's the real world, as if somehow like the book was just manifested into existence by people who had like a particularly fantastical imagination. It's all, the book is what you're supposed to do. It's just that you have to improvise sometimes. And I think that people pick up on this idea of, you know, oh, there's these tips and tricks. And here's the real way to do it. And then there's all this nonsense. And I think one of the things that can really help with contact with higher level providers in a hospital setting, an emergency department, or when they go to operating room to, you know, do airway management and whatnot, or when they go up to critical care, is really give them the understanding of like, not only how do you do this, but why. Why is it done this way? Why is it important you do these steps? Good educators are going to tell them that, but like, you can tell somebody, the evidence very clearly shows that like people retain about 20% of what's said to them if you just do traditional education. And if you really do like all this cool flipped classroom stuff that we do and like hit it with simulation, you maybe get up to like 70-80%. But there's still a 20% deficit there that people are just not going to have, that they can fill back in with that practical experience with people who have done it a million times and know, here's why you need to do this.
Mm-hmm. Yeah, I think that's like, we have like the stat training that the providers like participate in is where we have like a trauma patient come through and it is just the most chaotic thing ever. I don't ever feel like we ever successfully save the mock patient, but going from there, you do take things away like, okay, well, in this situation, we would have done X, Y, and Z. It probably would have been more efficient. But then you remember that, you know, oh, I kind of did this, I did that, or we were looking at this thought process or whatever. So like how you said, like, I think it's the hands-on of teaching why you're going to do it and having the hands-on portion, because I feel like a lot of our newer nurses who move into a trauma bay do receive a lot of retention after they go through like a stat training.
Yeah, and understanding the why, I think, is a key point. I mean, the case I always use is the paramedics bring in a patient in AFib with RVR, and they've given cardizem to slow the rate down. It's like, did you ask if that was actually needed? Like, why did you do it? Are you just responding to, this is AFib with RVR, we give cardizem every time? Or did you ask why they're in AFib with RVR? Is this their version of sinus tach because they're septic? You know, we don't want to control their rate in a lot of these situations. And I think that's a good example of EMT thinking, or just task, oriented thinking. Like we see AFib with RVR, we give this medication every time. Well, that's not really true. You have to think about the underlying cause. You have to think about the why. And so I think that's key to teaching some of these new folks.
What we used to derisively call cookbook medicine, right? Where they just are like going down a list and they're not actually applying any critical thinking.
Right. That's the danger in, protocolized stuff where you do the same thing every single time and there's no variation. And, we give aspirin every single time we hear the word chest pain. And, why are you giving aspirin? Do you think they're having an MI? If the answer is no, you probably don't need to be doing it.
I have a brief thing I say at the beginning of every class. It doesn't matter whether it's EMT, advanced EMT, paramedic, is I say the practice, like even though we're doing like the babyest version of medicine, we're still approaching medical problems from a critical thinking aspect. And there's a difference between magic and medicine. Magic is you show up, you don't know why it happens, you don't know how it happens, but you give them the magic aspirin and maybe it works and maybe it doesn't. And medical thinking is you give them the aspirin. If it doesn't help, well, why not? What's the pathophysiology behind that? Why would it help? Why wouldn't it help? And like being able to troubleshoot when things don't go the way you think, rather than the good old like, I don't know, it sounds like a doctor problem. Like, well, that's just passing the buck.
What advice do you guys have in general for just new people, new physician, new paramedic, new EMT, new nurse? Do you guys have just general advice for people new in the field?
I would say keep your mind very, very open. Learn from people, and we all kind of gravitate towards people who have a style that complements ours, that agrees with ours. But you also need to learn from the people who have a totally different style. So as a doctor, I can learn from people who do things very different than I do. And I'm not interested that they do things differently. I'm interested in why. Why do you do this and I do this? It doesn't mean I'm going to change what I do, but it might. In the beginning, medicine, and especially emergency medicine, can be daunting. I mean, it's the wild, wild west in the emergency room. So you have all of the normal medical things, and then every day you're going to come across social things and drug stuff and all sorts of things that you never once learned about at all, but you have to know how to solve the problem. It's kind of cool, but it's also a little overwhelming. So keep an open mind, take pause and relax, ask a lot of questions, lots and lots and lots of questions. Work on growing your confidence gradually and reasonably, but always have that as a goal of just continually being more confident in what you do and how you do it.
Yeah, I agree with that. So like with new grads coming in, it's definitely, we always try to tell them like it takes a good 6 months when you first start to finally feel like I can go in one room by myself and come out and feel like I did everything I was supposed to do. And then a year before you feel like you're knowing, like you know what you should do. And then by 2 years that you're efficient at what you're doing. And so we always just really try to, at least I recommend to people, like try to stay on that path. Like, yeah, some people may reach it sooner, some may take a little longer. But I've noticed with emergency medicine, a lot of the people who come in for nursing wise are like kind of almost that adrenaline junkie, and they're like, oh my god, I want to do this and I want to do that, and it's like, well, yeah, it's great to learn all the big stuff too, but I'm like, but this is our basic stuff, this is our bread and butter. You need to know how to do this efficiently before you can kind of move over to something that's bigger or different or more exciting, as what they would call it. So that way you can be a well-rounded nurse and not just always looking for the big scary things that everybody's coming in for, like I want to be in the trauma bay or whatever. So those are one things we always try to tell everybody. It's just, just take it one day at a time. Like when I came down from med surge, I was shocked by the emergency department. I was like, oh, I probably should have did a shadow day. I had no idea what I was walking into. I was like, this is crazy. So also having that understanding of what it is that you're going into. Like there's so many people who fantasize about it. They don't take the time to actually investigate the career path they want to go into. At least for nursing, like everybody gets that clinical experience where you work med surge, you work onc or blah, blah. It's like, take the time before you're hired to shadow. Like a lot of places let you shadow so you can actually see what it is that you're really getting into. Because then they'll have people who walk in and they're like, this is not what I thought, this is not for me, but they could have been a fantastic nurse there, but they didn't get the opportunity to kind of walk in prepared. Or you have those people who come in and then they're just like, oh my God, this is, this isn't for me because, whatever X, Y, and Z. So I really feel like you should shadow beforehand and just be really aware of where you're going and how long it's going to take for you to get there. It's not something that's going to happen instantaneously. And then from the charge side, I would also recommend for being a charge that you are able to, as we were talking in the beginning, just communicate and help develop your team. So a lot of that too, like, we kind of get new grads in and you're just like, oh my God, this person's terrible. Like, they're not going to be able to make it. They're not a good fit here, whatever. But you as a charge nurse, like, you try to see their potential, grow them, like talk to them like, hey, what are you not seeing? What can I help you see? Where can I help you learn here or learn there? And just kind of always try to mentor them on the side. Like, it doesn't have to be in front of everybody where you're like, oh my God, that was the wrong thing to do. It's like, no, hey, next time when you go in there, think about doing this or this, or, or what was your thought process? Tell me what you're seeing. Let me help guide you down the appropriate road or, a more efficient road or how to accomplish a task. So those are one things I like to see as out of a charge nurse. I know I've seen multiple people who come through. They're like, oh my God, get rid of this guy. Send him home early. Can't deal with him, blah, blah. It's like, but we have to grow everybody because if you can grow everybody, it grows your department, which allows you to provide better care to the patients that are coming in. So
I think that's a great perspective. Because especially when I was a paramedic, like I almost failed my second to last rotation as a paramedic. And if people had just given up on me, I'd have been screwed. But I had people that actually cared enough to mentor me and get me to where I needed to be, as a brand new paramedic. So, I mean, some people are, I'm probably just slower than the average person to learn new stuff. But I think that's a key point is we can get people where they need to be, with some mentoring and pulling them aside as opposed to addressing it in the moment in front of other people. I think that's great don't embarrass them, that's not going to help anything. Pull them aside and say, hey, next time we need to do this a little bit differently, but don't do it in public. I think that's great advice.
Always be willing to learn as a new grad coming in too. Ask questions. You don't have to have your hands on everything, but ask questions oh, why was this the thought process, or why are we doing that, or whatever? Because it just helps build your base of knowledge too. I've been oh, I could have looked at it differently, or this is how we could have approached it, or whatever. So, and
questions can be helpful avoiding errors too. If I get a question from a nurse, why'd we order this stuff on this particular patient? I can be like, oh, that's because I ordered them on the wrong patient. I'm glad you asked the question. So before we do a bunch of errors, or miscommunicate about a bunch of stuff, it's great when you ask questions if something doesn't make sense so that errors don't happen.
Yeah, I think I had my first cardiogenic shock. Why are we doing this? This makes no sense to me. And he sat down and explained the path of. He's like, well, this is what's happening with them, blah, blah, blah. It's not like regular shock and blah, blah. I'm like, okay. So this kid is actually really sick. He's like, yes. I'm like, okay. So.
I think the mentorship thing is very, very important. So when you're new, find a mentor or multiple mentors. And when you're seasoned, mentor people. Medicine is really one of the last apprenticeship type careers, everything in medicine. You can read, you can watch lectures, you can ace every exam, you can intubate flawlessly on the rubber mannequin, you can do every simulation fine. But it's a totally different game when you put your hands on a real human with real problems. And the people to learn that from are the people who've done it before. And if the apprenticeship, mentorship thing goes away in medicine is going to deteriorate into an abysmal place. So it's always teaching people below you and learning from people above you constantly.
Yeah.
And how big a difference did it make on the ambulance when you're a brand new EMT, you don't know anything, you're doing your ride, and you get a crew that's super burned out, they don't want to teach you anything, you're just, essentially spiking their trash into the trash can as they throw it in the back of the ambulance, and they don't want to talk to you, they don't want to teach you, versus the crew that loves their job, they want to teach you how to do stuff, they force you out of your comfort zone. I mean, that's such a different experience that can make or break a lot of these new EMTs. Versus, it's when they're deciding if this career is for them, when they're doing their third rides, and a bad crew can make them decide, nope, definitely don't want to do this. This was a huge mistake. Versus, riding with a great crew, you're like, oh man, this is the best thing ever. I definitely want to do this.
Yeah, absolutely. Especially because you can also get there's the and these Star Wars things, so I know I get this. There's like the Jedi mentors and there's the Sith mentors, right? There's the light side and the dark side ones. The Jedi ones, the nice ones, are the ones who are going to be good patient advocates, who are going to recognize their part in this chain, right? This continuity of care, and we're going to recognize like it's time to approach this with some humility. I'm just like part of this system, and the evil Sith ones, right? The dark side ones are going to be the ones that are burned out and grumpy and spend the whole time complaining, and every patient is full of crap, and this person's just a drug seeker, and like dispatch is an idiot and fire is an idiot, and that nurse is an idiot and that doctor's an idiot, and I'm the only person that matters in this. And it gets in this very cold, hard kind of like calcified shell around them, and it establishes this kind of really bad toxic culture. But people come to EMS for a lot of different reasons, and sometimes they'll absolutely resonate with that sort of like kind of like hyper macho, it's all about me, right? Like, you know, I'm the only one you can trust, and we've seen it plenty of times, right? And it's not unique to EMS, but certainly EMS is where my experience is seeing people who have that kind of negative outlook accruing, right, agglutinating these people to them that have a similarly bad attitude, until it can really tank the attitude of like an entire shift. And so, yeah, I think that mentorship is hugely important.
We pick up on those paramedics in the ER too, the ones that always come in saying this patient's full of crap, their report's terrible, they're just justifying why they did nothing on the patient. And I know when I see that paramedic, I'm going to have to be extra careful and take more time with this patient, because already going into it, I'm biased that this patient's just an anxiety attack. And I'm like, well, how do you know it's not a PE? You know, and I know I have to be more careful when I get sucked into that bias that particular paramedics will bring when they do their handoff report.
And guaranteed, these are the same medics who will complain they're not paid enough. They'll blame it on like, we're not paid enough. Well, I mean, you doing a good job is not going to get you paid more, but, you know, as an industry, if we did a better job, people would be more willing to reevaluate that, as opposed to looking and saying, these guys just complain and they drive people back and forth. So
I think we would be remiss if we didn't state that that's not unique to paramedics. That's ubiquitous. You have doctors who do the same thing, who will lead you down the wrong path. You've got nurses, you've got mid-level providers, you've got everyone on the entire spectrum is equally guilty in different ways, and you got to be careful with that.
Yeah, that's true.
I really liked your point about like find somebody who also has a different style from you. One of the best lessons I ever learned as a brand new baby paramedic, like I'd just gotten cleared of my my FI, was that we brought in a guy who was having very clearly a stroke, but his speech patterns were bizarre because he was only speaking in German and then occasionally in French. And his family was like, no, he speaks English, but he couldn't at the time. And I was like, oh,
those are fascinating neurological
things. I bet I know what this is, right? Like we learned about like Brokaw's area and Wernicke's area. So we brought him in, and I told the doc, you know, the whole time I was like trying to do my assessment in German, and then he'd switch to French, and I'd know like 3 words and be like, no, en allemand, s'il vous plaît, and back to German. And then got there and I said, I think he's stroking out this part. And the doc's like, whatever. And I went, wow. And I came back later, and he had in fact been stroking that out. And I was like, kind of full of myself, and I was like, so what was wrong with him? He's like, you got lucky. and at first I was like, God, this guy's a dick. But after a second I was like, that's true. I did get lucky, because this was it
could also be true that he was a dick, though.
That was also true. He definitely was. Like, you know, the evidence was very clear on that. But it was really useful to hear this from somebody I didn't like, but also was like, he's right, I did get lucky. I got so into the weeds with this guy. You know, luckily it was a short trip, but like I could have gone to Zebra Town on this. And it was really useful sort of reality check to be able to say, you know what, valuable information comes from all quarters. It's not just the people that you like and will tell you the things you want to hear.
Well, when you're trying to continually learn, also understand that you can learn a great deal from people who are a lower title than you. So like I can learn a lot from nurses. I can learn a lot from PAs, from NPs. I can learn from the CT tech. I can learn from everyone. So why would I be so pompous to only think that the only people I can learn from are equal or higher than me? Like I'm shutting myself off to loads and loads of practical knowledge if I don't keep my eyes open to every opportunity I can to learn from every single person I can from.
Yeah. Yeah, I can think of a bunch of examples from CT techs or X-ray techs telling me different things like, "Oh, you should order this test if that's what you're looking for." And you're like, "Oh, I'm glad you told me that. I'll switch to that because that's what I'm looking for." I mean, one person does not know everything, and that's not in emergency medicine. I think that's more clear than a lot of realms of life. Is not one person has all the answers or knows everything.
There's a reason that there's specialization for like every single industry.
Mm-hmm.